My name is Rafael Boscha, and I'm going to demonstrate this corneal transplant technique, Dsek. So, here we start with an artificial anterior chamber, filling its surface with Wapsol itself. I gently place the donor cornea, filling it to prevent bubble formation. I insert the first part of the anterior chamber very gently, so that the cornea stays well centered. I support this piece, then I take the second part of the anterior chamber and now I tighten it. You can't see it here, but I pressurize it so that I can now use the pachymeter and take several measurements. Based on these measurements, I calculate the average thickness of this cornea. With this average, I subtract 100 microns. I set it on the graduated scalpel. I subtracted 100 microns and now I'm going to make a tunnel. At that depth, I make this incision. Through this incision, I carefully take a specialized instrument so I can precisely start the process of tunneling, which involves creating the delamination plane. This particular plane is a very important and absolutely crucial step in the procedure, as it ensures proper separation and minimizes trauma to surrounding structures of the surgical procedure, because this particular step will be absolutely fundamental and critically important for us to successfully obtain a perfectly formed and viable lamella, which is essential for the subsequent stages. As thin as possible, providing better visual quality for this patient. And something that's very important, it's at this moment that we run the risk of perforation. So we need to be very gentle at this stage. Once we reach a certain distance, I switch from this straight instrument to a curved blade. And I continue dissecting until I manage to successfully get through this situation, all the way to the other side. So I progress little by little, without rushing, paying close attention, until I reach the clear area on the other side and am sure that the entire cornea has been dissected. You can see that this is a very meticulous, very careful job, especially because we're dealing with extremely precious tissue. Once that's completely done, I'll then disconnect this artificial anterior chamber, and then I will take this particular cord and subsequently use it so that we can precisely cut the disc, right? Here I'm using an 8.5 millimeter punch. I press down, then remove it. And there the cut is done, the 8.5 millimeter disc. Now I'm going to confirm that this cut was made perfectly, 360 degrees. So now I'm just confirming that it's completely separated. Here is just the end of the cataract surgery because it was a combined procedure. So we started with the cataract and finished with the transplant surgery. Here are the measurements so we can properly position the transplanted button. And now that we saw the button was all ready, we begin this step, which is the Descemet's stripping. So at this moment I'm using the inverted Sinski, which is an instrument I use to remove the patient's Descemet's membrane. So very carefully I use the Sinski to remove only the Descemet's membrane. I don't want this Sinski to dig into the stroma, because that would only make my job harder. So, by bringing only the Descemet's membrane, I keep moving in a continuous motion. After doing this, I confirm by stretching this Descemet's membrane on the surface of the eye. And then we can observe, by bringing along only the essential DCM, I am able to consistently keep moving forward in a smooth and continuous motion, ensuring an uninterrupted flow throughout the entire process. After carefully doing that, I then confirm this by gently stretching this delicate DCM or Descemet's membrane on the surface of the patient's eye. and then we can see that it came out completely. So now we already have the patient who has had their cataract removed. I have already implanted the intraocular lens. We have already removed their DCM, which was the main issue for this patient. Now, what remains is for us to implant the cornea in this patient, the corneal endothelium. So now I am removing the endothelium which will be implanted. I place this endothelium facing up, folded, with 60% on the upper part and 40% on the lower part using a cystotom. I push this endothelium and now, yes, 100% of this endothelium is facing down, which is what I want. I turn the cystotom to the side so that when I remove it from the eye, I don't bring the endothelium with it. And now I inject air so that the air presses the endothelium against the upper part, making this endothelium adhere to the rest of the patient's cornea. And here at EBOL we have fantastic technology, because at this moment, this maneuver is called the milking maneuver. So what I want is to ensure that between the donor cornea and the patient's cornea, there is no fluid in that interface. So we keep moving this instrument, performing a milking motion, removing all the fluid. But it's very difficult to know whether there is still fluid or not. And the eyeball microscope, it has fantastic technology because it has a tomography, a live OCT. So I can turn on this OCT and move around using the foot pedal joystick. And then, depending on the area I move over, I can see live whether that transplanted tissue is adhered or if it's loose. And then, postoperatively, we see a beautiful cornea. This is the 6th day after surgery. An OCT already at 6 days post-op showing a thin transplanted lamella for a Dsek. A really great result, a super happy patient. Refractive result, really great, and the whole team is very happy as well.